No, it gets more interesting than that. So anyway, so I published that paper. I present that paper at APA, American Psychiatric Association. That the finding of the paper was that, yes, if you change the name PTSD to PTSI, the stigma will improve.
Mm-hmm. Welcome to Elevate, the gathering spot for first responders, their families, and the communities that support them. Hello, Elevators, and welcome back to the Elevate podcast. I'm glad you could come back and join us. I've had several great guests in the past, and I'm bringing you another great one today. I was actually in a symposium just yesterday and heard about the technology that he's going to be talking about and the procedure that he's going to be sharing with you today. And I just can't believe how the universe puts things together for myself. It is incredible because I was just introduced to this process yesterday. It blew my mind. And now I've had him scheduled for this podcast for about 2 weeks, and we've been talking for 2 months. And he's now on my podcast talking about it. So before I go any further, don't forget to like, subscribe, share, hit that bell. If you're listening to this and you feel resonated to share this with someone that may help them, don't forget to share this with those other fellow first responders, healthcare workers, anybody that you think that the information that the Elevate podcast brings to you can help them. So before I go any further, I just want to go ahead and introduce Dr. Lipoff is my guest today, and I'm super happy to see him, and I'm super happy to meet him. And Dr. Lipov, go ahead and tell us about yourself and just a general overview of what you're doing.
Well, thank you for having me on the show.
You're welcome.
Really appreciate it. So I finished medical school in 1984, and then I was a surgical resident at Cook County Hospital. My mother took her life when I was an intern. So that made me very interested in psychiatry, alternative psychiatry, shall we say. So from there, I went to become an anesthesiologist and a pain doctor. Through an interesting set of circumstances, I figured out that an old procedure called Stellate Ganglion Block, which is an injection in the neck, designed for hand pain and headaches, takes away hot flashes. And then I tried to understand how that procedure works for hot flashes. And I came across papers that allowed me to predict that stellate ganglion block would work for PTSD. So the first patient was treated in 2006. The first paper that came out about that patient was 2008. Then it was replicated in Walter Reed and San Diego Hospital and Military Hospital. And here we sit today. A lot of people received it, and a lot of lives have been changed and saved by this.
Yeah, that's fantastic. So I understand blocks as I understand them when it comes to nerve blocks. So I've had multiple orthopedic surgeries. I've had 3 shoulder surgeries. Two have been recently in the last 2 years, and then one was 14 years earlier. And I know that when I got my block for my surgery, I couldn't feel my arm for about 24 hours. Right. It was just dead, right? So when it comes to this, that stellar ganglion block that goes, and how I understand it, and I just learned yesterday, they showed a short video of it, and they had the speaker had about a 15-minute presentation on it, and actually showed some patients having it done to them, and it goes just to the side, probably in between the carotid and the trachea somewhere, I would think that. So I'm a little anxious of wondering where it goes, because being a respiratory therapist, I'm very, very itchy around the if that makes sense. I'm very nervous around things happening to the neck.
I understand. So let me give you details.
Please. I'm super excited about details,
this. First of all, the local anesthetic block that you probably had is called interscalene block. So my teacher actually invented that. So we're not trying to numb up any nerves going down the arm.
Okay.
Right. So let's put that out of the equation.
Perfect.
So if you look at the neck, trachea is in the middle, as you well know. Mm-hmm. Next comes the carotid.
Yep.
That's a little further out.
Yep.
Then there is a anterior tubercle, which is a bone. If you feel that, there's a bone in there.
Yeah.
I don't know if you feel it. Once you feel the bone, that's where we need to go. So we need to go immediately medial to that, or right next to it.
Yeah.
So fight and flight nerves or sympathetic ganglia sits there.
Okay.
So the idea is, when I originally started doing stellate ganglion blocks was 1987. Then I did 30 years. That was blind, so basically by feel.
Okay.
So then we went by
ultrasound or
X-ray guidance.
Oh, X-ray. Okay. Fluoro.
X-ray. Yeah. Now it's ultrasound.
Oh, it's ultrasound.
So with ultrasound, I can see exactly where the trachea is, where the carotid is, any blood vessels are,
Yep.
where the bones are.
Yeah.
We know where not to go. So
yeah, we do.
you can feel pretty comfortable. People who are comfortable and are good at those procedures, it's a good, safe procedure done in decent hands.
Right, exactly. And I've had the laser surgery done to my eyes, and they offered me Valium, and I'm like, nah, I'm good. And I wish I would have taken it because it would have taken the edge off, because it would the surgery, the procedure itself was like, I understand now why they offer you Valium, and I thought, oh, I'm tough enough, I can deal with that. Like, do you do any type of relaxation for the procedure, or is it so simple, or do you do any local numbing at all, or?
So it depends on the patient.
Okay.
I prefer people getting sedation. When I had mine done, I was definitely sedated.
Yeah.
If you want to go on YouTube, my channel, you can see me having mine done.
Okay. We'll put
so-
that link in the bottom, his channel.
Yeah, about half of the people who have it done was local. So we number up the skin for everybody.
Right.
I give 2 minutes for it to set, which is important.
Right.
So the local has
Of course,
time to
Yeah,
work.
the lidocaine takes
What
care.
a concept. Yeah, and we give either Versed
Okay.
or other sedatives.
Yeah.
But absolutely for the people who want it.
Yeah.
I mean, it's still not fun to have a needle stuck in your neck.
Yeah, no,
I mean,
no
like,
doubt.
I'm not minimizing
Yeah.
it.
Is it a small, like, what's it, about a 22, 26?
22 gauge echogenic needle.
Okay.
So echogenic, you can actually see it in ultrasound guidance.
Oh, you can see it on the tip. Okay. Yeah.
Yeah, which is great.
Right. I used to assist with percutaneous trachs in the ICU setting, and we would put a camera down the trach, around down the ET tube, and I could see where the doctor. So I operated the bronchoscope while they looked and saw the needle coming through. That was visual. This is no different with the level of ultrasound we have nowadays. The ultrasounds are almost a black and white clear picture anymore, from the ones that I've seen. So,
yeah, it's really good.
Yeah,
and it's also, there is a section, and you can use Doppler part of ultrasound, and that makes blood vessels pop up.
Okay. Now, what about is fluoroscopy a little bit too intense when it comes to the radiation? Would that help? Would that be any benefit? Because I've seen I've seen procedures done under fluoro, and it's really, really clear, like when it comes to caths and stuff like that.
Well, yes and no. So I did 30 years of fluoro.
Okay.
The problem is fluoro doesn't show the blood vessels.
Okay. Yeah, because unless you light them up with contrast, but you're not going to do that. Yeah.
Well, yeah.
That's not,
so the way you do fluoroscopy guided stellates is you put dyes through the needle.
Right.
But you find out you're in the vessel after you hit it.
Exactly.
I want to find out about the vessel before I hit it.
Right. Exactly. And
the ultrasound is the way. I spent years fighting it, but then
and then you gave in. Yeah, it makes sense. I mean, when you first mentioned it, I thought, I'm like, ultrasound, or ultrasound, why wouldn't they use fluoro? But now that makes sense, since the fact that what you can see and can't see through fluoro. So that makes sense.
Right. Bones are not as important as vessels.
Yeah.
Vessels, soft tissue is much more important in this block.
Okay.
And then, like when I do injection inside the spine, I need fluoroscopy.
Okay.
But for this, it's ultrasound.
Gotcha. So when it comes to another reason why I wanted to have you on the podcast, we can switch gears for a little bit, and we can get back to this with if we want to. But the reason why I reached out originally to you is I was on a podcast as a guest, and somebody I mentioned something about the trauma that I went through more recently that kind of sent me over the top, the top of my mountain, if you will. It was, I didn't consider it PTSD because I was never diagnosed. So I called it a PTSI, and that's what I've been calling it myself for a while. But then other people, oh, what are you shouting?
In my pen?
I do see a pen. I just can't read what it says. I can't read. No, I can't read it.
It says it's PTSI.
It's PTSI. So let's talk about that for a minute, because even just yesterday, when the same lecturer that was up talking about, the SGB, she said PTS, PTSI, PTSD, it's all the same. It's just nomenclature and a billing base. Basically, the D for diagnosis is when it comes to insurances and when it comes to making sure that things are under an umbrella that D is important. But when it comes to just speaking about it in general, the PTS, PTSI, PTSD, are they all the same? Like can
No,
you clear that up for us? I mean, once and for all,
no,
someone who's
no, no,
in
no.
the industry and who speaks of it professionally, I really want to sink my teeth in and understand about these different alphabet soups for this condition.
So that's, well, I you're actually talking to the right guy about that. Arguably,
That's
I'm
why I
the
wanted
man
you
of
on. So
PTSI. I appreciate it. Anyway, so the PTSD term was introduced in 1980 in DSM-3, post-traumatic stress disorder, because that's when psychiatrists believe everything was disorder, this disorder, that, whichever way they termed it. Then in DSM-4, they continued to term PTSD, and then DSM-5 now, the same thing. So they're still there.
Right.
However, a lot of people don't like the term disorder because it's so stigmatizing.
it is.
That's why military people, I was actually in Congress talking about Stella Ganglion Block in 2010, and then they talked about how stigmatizing the term is. About 2010 is when they wanted to say drop the D, so PTS. Post-traumatic stress is what the Congress wanted to call it,
Okay.
which I really didn't like that term either, frankly, for a number of reasons. Anyway, so if you look at the history, though, so there was a committee in 1980. Part of the committee was Frank Ogbert, very famous psychiatrist. He came up with the term Stockholm Syndrome, which you probably heard of. So in 2013, he and General Shirelli, who was a four-star general in charge of suicide prevention for the Army, they got together and they went to APA, American Psychiatric Society, and they said we need to change the name from PTSD to PTSI, post-traumatic stress injury, for two reasons. Number one, the term is old. It doesn't take into account all the new science findings. Like you can do a brain scan, like a PET scan or FMR or MEG scan, and those will show you that there's a brain change. Somebody has a PTSD problem, right?
Right.
So Frank Ogbert, that's his baby, the term PTSI.
Okay.
And then, so they told him no, they being APA, American Psychiatric Association. So then in 2023, I published a study looking at what would happen if you change the name PTSD to PTSI.
You'd get more people
based
coming
on
forward.
3,000 people.
I would think more people would come forward.
Right. Exactly. Well, shockingly, you know that.
Yeah.
The only people don't know it is psychiatrists.
The ones
Anyway.
Sometimes you got to let the dogs teach the owner, right?
No, it gets more interesting than that. So anyway, so I published that paper. I present that paper at APA, American Psychiatric Association. That the finding of the paper was that, yes, if you change the name PTSD to PTSI, the stigma will improve. If the stigma is improved, it's very clear people are not going to kill themselves as much. Shakalaka boom. Very simple, right?
Right.
You'd think that.
You think that.
Well, not quite. It's not the end of the story yet. So Frank now is he is now 87 years old, so he's kind of old. So he handed the reins of making the name change to me. So I'm actually his
understudy.
His understudy or his follower, whatever you want to call him. A pupil, hopefully a good pupil.
Yeah, good pupil.
Anyway, so to change the name officially in DSM TR, you need to go through a whole process. And it's actually a fairly straightforward process. In order to do that, you need to demonstrate on their website, it says, we will change the name if you could show that the current name produces harm. Very simple.
Okay.
It's a simple, right? So keep in mind, a number of names have been changed, such as learning disability.
Yeah.
Oh, stigmatizing.
Yep.
Right.
I was labeled learning disabled all the way through college, through the early 90s.
I'm dyslexic.
I am too. And I was learning disabled, and that was, that was a name that, it was I got picked on from it. I mean, I probably have some childhood trauma because of being picked on because I was in the LD classes. I was the dummy,
You're the special child.
Yeah. But then who's the ones that are calling me and asking for help now in my older years because I'm really good at what I do.
No, I got you. Anyway, but here's the point I'm making, though. They have changed the names based on stigma.
Yeah.
So learning disability is now learning differences.
Learning differences. Okay.
So I made that point in the letter to the APA. I sent them my survey, right? That shows pretty clearly that if you change the name, stigma will go away. Guess what they did with us? They said, not enough data. Goodbye. Thank you very much.
How many people do they need a study from that says it's good data? Are they as bad as the FDA then? Like when it comes to changing something in the FDA, you make a product and then, oh, I want to improve this product. Well, you got to go through the whole process.
I think they're worse, actually, in my opinion.
They're worse than the FDA.
But,
oh, no, because I'm very familiar with FDA process because of being in medical supplies development a few years in a row. So,
well, anyway, so to give you a direct answer, the original name was PTSD.
mm-hmm.
PTS is something that was developed for military, try to reduce the stigma.
Right.
The next name change should be PTSI. So my plan, just so you know, and we'll see if it happens, how fast, but it will happen. The question is how fast. So my plan is to have a Senate hearing about that. So I would like to bring the APA people to Senate. I will come. Hopefully, as a four-star general may want to come, he may not. I can bring a lot of special forces people with me who are very interested in the name change, and some other people.
Yeah.
And I'd like to have an objective body basically say, why you're not changing it. Explain the science here.
Right.
There's no science.
There's no science. It's just a name thing then. So they're no different. They're all the same. It's just a matter of being able to take away the stigma and normalize this mental health issue.
Except, well, exactly, but they're not all the same. The reason I said is they're not the same. PTSD actually kills, while PTSI enhances better care because it reduces stigma.
Because it reduces stigma and it normalizes it. I see what you're saying. So
right. It says it's a medical condition.
It's a medical condition.
No different.
Yeah. No difference than heart pressure or blood pressure issues or cholesterol.
If you look at my if you look at my website, it's ptsi.com. It has everything I listed there. It has TV appearances about this I've had. It has my write-up that I sent to APA. If you're interested in that, it's all out there. Wow. Absolutely.
That's amazing. Oh, that's so great. That was a great segment because that kind of, when someone asked me that on, because I kept on calling, I called mine an injury because I didn't have mine. There was a few things in the list of the criteria that I didn't fall under. So I just inherently said, well, it was more of an injury because I've gotten better from it. Because I raised my hand pretty quickly after having my issues, right? I've always been okay with counseling and therapy, and I've been pretty connected to my mental health most of my life. With being bullied a lot when I was younger, and that stigma placed on me as the dumb kid in the room and learning disability, like I found ways to make sure that I was okay on the backside. I had great parents that put me in better school systems because of it, got me involved with better education because of it, and I feel like I came back out on the other side of all of that could have sent me down a weird hole. But like to me, when I had my incident, it was a very, very traumatic. The first traumatic incident was very, very much what the PTSI criteria is, except for it didn't affect my everyday living, and it didn't last for more than 30 days because very shortly after my first incident, which was a family of 4 who died from carbon monoxide, and when I came home from that run, my daughter knew the little girl that was in the house. They were friends. And she was crying in the kitchen, "Baby, what's wrong? My friend and her family just died." I'm like, "Oh my gosh, babe, I'm so sorry." But she saw me in my uniform. She saw the look on my face, and she goes, "Oh my God, Dad, you were there." And I go, "Yeah, baby, I was." "Why didn't you save them?" So now here I am.
That's horrible.
Here I am trying to answer to my.
That sounds awful.
Horrible. I mean, and it's been one of those things that it defined my career because it messed me up, and I didn't know it messed me up. And I had some issues in the early moments. I had some forgetful moments. I lost a couple of hours here and there once in a while. I was more cranky. I was all those things on the list. And then approximately about a month later, we ended up having 9 carbon monoxide runs in one shift because of an electrical outage in my area without a storm, which without a storm means no wind. So the wind, the way that, and I work out in a rural area. So the generators that would create the electric, they put off carbon monoxide, right? When there's no wind to blow the carbon monoxide away, the house is breathable and it sucks it in through the vents. So we had one after another houses go down with alarms. Now, fast forward into the evening, we had an entire house that did not have an alarm. 4 kids got rushed to the hospital. 1 was unconscious on our arrival. The generator was in the back. No one heard it. I was like, wait a second, we're showing signs of carbon monoxide here. Are you running a generator? How are you getting this electricity? Yeah, it's out back. They had it out back, sitting outside, but a fan in the window. So it was sucking the carbon monoxide into their small little home. And so I got off that shift. We had another one at 5:30 in the morning. The guy comes up, shows me the alarm. Hey, well, this thing's going off. I'm like, thank you for leaving your home. Thank you. You did the right thing. Is there anybody else at home? Oh yeah, my wife's there. I'm like, call her now. And he's like, what? And I'm like, call her now. The first time I ever put anybody in my truck and then ran hot back to their home because she wasn't answering her phone, right? She was fine. Everything was fine. Nobody died in that day. Thank goodness. But I got home the next day.
Wow.
I got home the next day. And why I call this my injury is because when I got home, I started flipping out. And that's to put it lightly. I called a mentor who was in my debriefing from the first run and said, Chief, I'm not right. I don't feel right. I'm not going to hurt myself, but I don't feel right and I don't like it. What do I do? And she's like, are you in a safe place? Yes, I'm in a safe place. All right, I'll be right there. She came to my side. We talked for 2 hours and it was deemed that I should go try to get some form of therapy, right? And so she had introduced EDMR to me. I think I'm a dyslexic, so it's EMDR or EDMR?
EMDR.
The M is first. So EMDR, yeah, the rapid eye movement therapy. I went and did that a day or two after I had this meltdown, and I only a few treatments and I got better because I approached it in the now. So I never fell into the other category of more than 30 days of all these things happening to me. So I just inherently said I had an injury and I got better from it. And I'm still doing good from it. I am not triggered as like I was. And then come to find out my ACEs score really plays into this because I had a childhood friend who succumbed to carbon monoxide and became a anoxic brain injury and mentally disabled from carbon monoxide when I was in college.
If I may, Kyle, you may want to define ACEs.
ACEs?
Because not everybody knows what
Correct.
that is.
And we're everybody's learning more. So ACEs is the inherent childhood experiences or adverse childhood experiences. And what it is, it's a standardized test of 10 questions. And what that does is it goes through basically anything between 0 age and 18, anything that happens to you prior to then, you answer those questions based on that time of your life of your recognition.
So let me give you some. If I would like to give a little color to that.
Please.
So ACE is actually a very powerful predictor
It is.
of long-term sickness. So some of the questions there are, have you seen anybody killed in front of you? Has anybody in your family been admitted to penitentiary?
Yep.
Things like that. Right? So all of those, especially under age of 10, that actually changes the DNA significantly. But you can change it back by doing good things,
right,
which I think you're doing.
Right.
So ACEs is a huge predictor of problems.
Right. And I was eventually going to get to that because that's one big thing that that one of the other speakers yesterday in our symposium spoke of. Like, if you don't know what ACEs is and you don't know your ACEs score, it is imperative that us as first responders know that score, because that score, when you get that score, you can do some research and find out why, unpackage that, and then you won't go on a run that may trigger you to something that you don't even remember happened to you when you were a little kid, right? Because there are things that we block out as young children that happen to us. And of course, there is child abuse, sexual abuse questions on there, not in depth. It's just, did anybody touch you? Blah, blah, blah. So
yeah, it's pretty
straightforward. Yeah, you can take the test. Actually, the person I was sitting next to yesterday is an old high school friend. She's a dispatcher, so first responder. Yes, everybody, let's agree. Dispatchers are first responders. Yes, they are. They help us, so they are first responders. There's a big argument right now in America, and we need to get off our high horse, and they are first responders. So I hope that she's listening to this, and that's for you, Laura. I told you I'd do a shout out to you and the fact that some places still think that dispatchers aren't first first responders, so they're not qualified for things. They are.
They
However,
got traumatized just like you
yep.
guys do.
So I was sitting next to her. She had not heard of ACEs score. She looked it up on her phone in the moment. I said, yep, that top one, click on it. And if anything says ACEs score, it's not just one website. It's all the same questions though. But you can go on and you can take this score online. And I'll go ahead and find one and put it in the
By the way,
link
do you
below.
know where it came from? Do you know where ACEs score came from?
I have heard it before, but I can't regurgitate it.
Interesting story. So Kaiser Permanente.
That's right,
California,
Kaiser. Yep.
they were trying to figure out how to do weight loss. And they found if you ask ACEs scores is developed as part of that, they found if somebody is 5 or higher ACEs score, they will never lose weight.
Wow.
Because the mental injury is so bad. Isn't that interesting?
That is interesting.
That's where it came from.
Interesting. Yeah.
Anyway,
well, and
that's the story.
on that note, there are many things, and I've got something I can put in the notes below that is just a quick overlook. Everything goes up. Higher your ACEs score, the more chance for heart disease, the more chance for diabetes, the more chance for early death. There's all more chance of suicide. Those numbers are crazy because if you have a high ACEs score, your chance of suicide is 500% more than someone with just below the midpoint. And one thing that they said yesterday that I did not read yet was that they did ACEs score in the penitentiary. And they found out that these convicts all had an average ACEs score of 7 or higher. They had an average ACEs score of 7. Average, sorry.
Makes sense.
Okay.
Makes sense.
So when they had the same type of, the person that was talking yesterday said that they have, through their Save a Warrior program, they have had over 2,500 people come through their program. And what is the average ACEs score of the people that have been through their program, do you think, that are all first responders or military?
6.
Actually 7, the same as the incarcerated.
Oh yeah, of course.
So
I deal with a lot of special forces.
Right.
Those guys had tons of trauma
prior
as children.
Right. So hear me now, all my elevators out there listening to this. Please, please, please do yourself a favor and take your ACEs score if you don't know what it is. And then if it is, 4 or higher, seek guidance.
I think 5 is a cutoff.
5 is a cutoff. Okay. Yeah, because I'm on that borderline.
I don't recall.
Yeah, I'm on that borderline. I asked and I could ask you because I've asked a couple people. I believe I know the answer, but I was the incarcerated question. Like, is anybody in your home incarcerated? Like immediate family. I never had anybody go to my uncle, my dad's brother. He went to jail, and he was in prison for something he did. But that wasn't direct. I barely knew him. But my brother ran away from home at 15. When he came back, mom and dad decided to put him into an all boys school, which was kind of like, it was called Buckeye Boys Ranch. And it was almost like, it wasn't quite juvie. It was like the level before juvie. It wasn't like the illegal version of going to child prison, right? But it was close. I mean, I've been there, and I visited Buckeye Boys Ranch as an older teen through my learning disability group. We actually took a trip there to see, hey, make sure you don't go too crazy overboard on things, because this is how you'll live. So
that's your next step.
Yeah. So I do call that. I do personally call that an incarceration for my brother. But I also watched my sister overdose in front of me when I was 10 years old. So now she didn't die, but there was not alcoholism or drug abuse by my father. My father was a recovering alcoholic, and he was an alcoholic before I was born. Oh, well, he was always an alcoholic. He wasn't into AA until after I was born. So I didn't live with an alcoholic father in the alcoholism. It was the post alcohol, whatever you would call that, the recovery stage. So that's when I lived with my dad, because I was 8 years closest to my oldest sibling. So I was the oops baby, right? But yeah. So, but still, I still had someone in my home that was an abusive drug taker, which was my sister, who was actually very, very close to me. And I spent a lot of my time with, because I had 2 working parents. So that was one that I had to bump up to, I went ahead and put her in the category, just like my dad was for them when they were.
Well, I think one of the things to remember, I mean, it's how you perceive it, right? So your perception that she did try to kill herself. Your perception is your brother didn't really go to real jail, but it was close enough.
Mm-hmm.
So ACEs would count anyway.
Yeah, and that's what I figure. So I've got to retake my own ACEs score, because as I've unpacked a few things that I need to unpack as I've gone forward and preaching about normalizing the stigma and normalizing mental health in the first responder world, I have to make sure that I keep on reevaluating myself, and if anything comes up, and it does, it's weird. I'll be talking to someone and something will come up that I'm like, oh, I need to unpackage that, you know. So and one of the things that I had to unpackage, and I'm still slowly unpackaging it, because you can't unpackage it overnight, is the ACEs score. So I recommend anybody and everybody that is a first responder listening to this, or in healthcare, that could be possibly having PTSI, you know, symptoms. And there's a long list of symptoms that if you go and you read those are pretty standard. The sleeplessness, the irritability, the nightmares, you know, those are just some of the high level ones. But if you read through that list of what are symptoms of PTSI, then please take that ACEs score, so maybe you can start unpacking that and seek a professional to do that. Sorry, a little bit of a soapbox.
No problem. You're a true believer, just like me.
Yeah, exactly. So when it comes to, let's go back to, you know, the what is, I'm on your website right now. What is the dual sympathetic reset? Is that just like what is that in terms of what we talked about earlier?
So this is the next level of Stellate Ganglion Block. So I did Stellate Ganglion. Let me tell you where it came from, and I'll explain the biology of it.
Perfect.
So I was treating a lot of people, especially military, and then so there's one guy came in. He was a sniper, and he was in really terrible condition. So I did the block on him, and it didn't work. So I was pretty nervous about him.
Okay.
So nothing works 100%.
Yeah.
So before I got into the PTSD ward, I was doing hot flash work. So I was invited to teach them in Norway a couple of times to do those. So I learned to do a C3 block, which is it's like a stellate only higher up.
Okay.
So I took that guy, the soldier, I took him back. So C6 failed. I did the C3, and his symptoms stopped like a minute later. So I was like, well, that's weird.
What? Yeah. Okay. So just going up one more vertebrae. Yeah.
Well, no, actually
three. Okay. From where it goes. Sorry. Okay.
Right. But then I found the explanation in the book that's been out of print since 1972. It's called Stellate Ganglion Block by James Moore. And turns out the fight and flight nerves, sympathetic nerves, come out of thoracic spine up to C7 and go up to the brain via vertebral artery. The other half of those nerves go up to superior cervical ganglion and go to a different part of the brain through C3 via internal carotid. So the point is, when you're doing a C6 or C7, you're only doing partial sympathectomy.
Okay.
Temporary. When you do 2, you're doing a more of an impact. And I think it works a lot better.
A synergistic.
That's why we're doing it.
Yeah, a synergistic.
Correct.
Effect. So you still do both. It's not one or the other.
No, I do both.
Yeah, do both. Just to kind of, okay. Yeah, and that's important. I want to just go back for 2 seconds there. What you said at the beginning is nothing's 100% effective. That you have to know that there's options out there. And that's why I brought the Elevate podcast to the platform of YouTube and all the different places that you can listen to it on Apple and Spotify and iHeartRadio, is because I want to make sure that our first responder world, anybody who tunes in and listens to this podcast, is that it's not just all about talk therapy. Don't get me wrong, therapists are needed to help guide you at times, but there are options. I've had several different options already on my show, and it's only been 5 to 6 weeks big. I believe you'll probably be week 8 or 9, depending on how it works out. So it's one of those things where we're not even 10 weeks in, and I've given 3 or 4 or 5 different options of things that you can do and you can start. And that's important to me, because I think part of the stigma and normalizing this is to let people know that, okay, you heard of maybe somebody who went to get EMDR and it didn't work for them. So you're not even going to try anything because that didn't work. Hello, everybody. Let's make sure we know that there's all kinds of things. The studies that were done on the brain have been amazing, and we have learned so much just in the last 10 years about our brain that we never knew before, and there's options.
I think that's true. And then, the other thing is, it depends. A lot of things we currently do actually work much quicker than it used to be. Like, if you look, conventional medications work, it takes 6 weeks to 12 weeks to work, and efficacy is relatively low. So Stellate Ganglion Block, or DSR, can work 10 minutes, 20 minutes.
Right.
Ketamine
Yep.
works pretty
That
quick.
was another thing
Right?
they sprinkled
Those
on
kind
yesterday.
of things. Right. So the point is, and if it doesn't, there's going to be failures for everything. Anybody who tells you 100% of the time it works, that's not possible. That's a lie.
Yep. And there's and I know, and I'm not a naive enough that through my own trauma that I've dealt with and I've got EMDR on, I'm not saying that I have another incident where it sends me back into a place where I need to get a next level of help, or maybe I'll try EMDR again if it does and it doesn't work. But I know now there's options, and that's so important. You know, another big thing about the Elevate podcast and what I'm trying to bring to people is that when I came into this industry, or with anybody prior to, honestly, anybody prior to even a year or two ago, came into the first responder world, we didn't talk about this during training. We didn't talk about this in our academies. We didn't talk about this stuff in our education to be put. They taught us all the X's and O's, if you will, about how to do CPR and how to start an IV and get all that stuff. But they didn't talk about after the fact. Maybe they sprinkled it in a little bit, or they told the battle scar stories, but that's not enough. We need to know why it affects us, and why it affects us includes ACEs. It includes our brain, our neuroplasty, our the trauma that we get that we don't even witness, that we just hear via like the dispatchers. They only hear the trauma. They don't see it like I do when I go on scene. They hear about it just as bad. Okay. That trauma.
Pretty plenty.
Yeah.
Plenty.
Yeah. So it's one of those things where we just have to really, my goal is to get into the schools. That's my number one goal, is to get early into the schools and not just do a 2-hour lecture. Hey, everybody, here's Kyle that talked to you about your ACEs score. No, that's not what I'm talking about. I'm talking about true change, which we all know comes, people say 22-day change your habits. 66 to 250 days does it take you to make a new habit. I'm not saying that I want to teach somebody for 250 days straight about their brain and ACEs, but we need to start a pattern. We need to start
just recognition.
Yes.
I think the key point, that's why vocabulary. So look at how you start the show. PTSD, PTSI, and PTS are the same. No. Name is reality.
Yeah.
Right? So if you call somebody PTSD, it's a lifestyle. You got it.
You got it.
You live with it forever.
You're stamped. Yep, you lived with it forever. You're disabled.
Who wants to
You're
do
disordered.
that?
Yeah.
Who wants to do that?
Yeah.
So if you look at my PSA on my, actually you can put the PSA from my website.
Okay.
There. It's beautiful. Basically, it talks about broken leg.
Yep.
PTSI is the same thing. You can diagnose it and you can treat it.
And that's exactly what we do.
Simple.
Yep.
It's a simple concept.
Literally what
and
we
it's
talked about.
Biologically true.
Yeah. It literally, yeah. And this was another thing I got chills thinking about what you just said. So, it means that it means that I'm passionate, right? So,
exactly.
So one of the things they talked about yesterday that really put it in perspective, and I'll share it with everyone, and it's not my original thought, but what they said is, in the fire service, right? This was a fireman talking. In the fire service, they are very brotherhood, right? They're big on the brotherhood. Somebody slips and falls on fire scene and breaks their leg. What happens after that person goes, gets their leg set? Now they're in a cast for 8 weeks while it's healed. The brotherhood wraps their arms around them on that injury, right? They bring them supper after the surgery. They call on them, hey, do you need me to go to the store with you? It's like the whole, it's like the church thing, like the church people do all kinds of stuff for the people that are in need inside the church. No different and I've witnessed this, 2 shoulder surgeries. I've had my partner show up at my house with cookies and, hey, can I do anything for you? Ask my wife if they can go to the store and get anything. I've had that happen before, right? That's the brotherhood. That's a physical injury. That's a no-brainer. Everybody's like, yeah, I'll help you out. But when it comes to the mental injuries, we're not doing that yet. We need to be able to do that just the same. And
I agree.
And normalize
if you need help from me to do that, I'll happy to volunteer my help to that.
Right. Yeah,
because that's really important.
Well, that's a perfect segue into the next thing I wanted to ask you is just how do people get a hold of you? How do people, where I'm not sure exactly where we're doing this via Zoom. I'm not sure where you're located, what part of the country, if there's other places that you endorse or other places that do, other clinics that do what you do, and how to find that. If there is something on your website, share with us how people find you or find that type of therapy.
So I am Chief Medical Officer for Stella Center. So if people go on the web, stellacenter.com. So I'm the medical director. So our flagship is in Chicago. So we have, I think, 20 or 30 people currently doing it across the country. So you can go on Stella website. We'll send you the website.
Okay.
And then people can look it up, and we do ketamine, and in some of the centers we're starting to bring in other things like TMS, whatever it takes, but it's all physiologic. And we do, the cool thing that we also do, we have a great team of nurse practitioners, doctors, nurse practitioners who know a lot about pharmaceuticals, but the main focus is they assess the people, make sure they're in the right candidates for treatment, as well as they do the follow-up and kind of reintegration after that,
Okay.
which is really important.
Yeah, very important to have that medical follow-up and be under the care even after pre and post. One of that sparked another question I had real quick. One of the things that the gal mentioned yesterday in the lecture that I saw is she mentioned that you have to have the diagnosis. You have to have that. You have to be in that category 5. You have to be diagnosed with PTSI to get this therapy.
Well,
or insurance
currently, let's stick to PTSD. Let's stick to the term PTSD.
Okay.
I mean, basically, the term PTSD is still being used. It will be changed,
Right?
But so there is a questionnaire, PCL-5, I think.
Yep.
You're talking about.
Yes.
Yeah. So there are 30 questions.
Yeah.
And our nurse practitioners will do the assessment beforehand.
So what I guess where my question is someone like myself that was in the beginning stages of what the symptoms are of PTSD, for lack of better,
Right.
for a non-neutral.
Let's stick with that for now.
Yeah. For those early stages of it, but then feel that I'm on the back side of it now, and I was never actually stamped with it, right? I was never actually diagnosed by a physician or by anybody that put me into that category. How does this procedure help those that don't have true PTSD but may have other things that it could help with? How do they get that approved? Or is it not? Is it completely not made for that, for people that aren't truly diagnosed?
You got it a little confused there, I think. So basically, that's the beauty of having nurse practitioner that will talk to the patient.
Right.
And they will make an assessment about depression, anxiety,
Okay.
PTSD, suicidal risk, all of that.
So there's other factors.
Okay. Yeah. We don't, it's not just a PTSD company.
That answers my question then.
It's a multi-level company. And
what
the reason the people reach out to us, some of them go, I've been diagnosed with PTSD, I want to try this. They know exactly what they want. And some go, I just don't feel good.
Yeah.
I don't know what that means.
Right. I'm just unhappy. Yeah, I'm unhappy. I'm not who I used to be. Yeah. Is it my testosterone?
So that's why you have.
Yeah.
But the point is, that's why a psychiatric professional now will unpack that.
Gotcha. Perfect.
Because it's not just one diagnosis.
Gotcha.
Because SGB or DSR does work for depression and does work for anxiety.
Okay.
How many people are interested now? By the way, the other part, one of my interests also is children. So I treated my kid when he was 10. A lot of people are really not that comfortable with kids. I am. But the point is, pediatric PTSD is something people don't understand and ignore, which is not a good idea.
Not a good idea. No.
Look at the suicide rate in teens right now.
Huge, unfortunately.
Yeah.
So I guess my next question, and then we'll wrap this up, and I am a horrible procrastinator. I procrastinate like nobody's business. Does it cure procrastination? I laugh at that because I have done procrastination courses, but I procrastinate to do the courses, so I never get through them. So does it do anything to help that gene or whatever that may be?
So I'm gonna give you an answer that's maybe. It's a maybe answer.
All right.
But let's put it together. But think about it in a scientific terms.
Okay.
So we do know that if you think about it, like I took care of this guy who was a sci-fi writer. And he said, my chattering monkeys in the brain stopped chattering after I did the block.
Okay.
Interesting description, right?
Right.
So think of your brain like a computer. If your RAM is full of crap, it's going to take a long time to go anywhere. It's a slug to go anywhere. Now, if you reboot your brain, which is I think what this does, your procrastination, I think, will be better because you can focus.
Right.
If you can focus better, I'm not talking about ADHD and any of this diagnostic craziness. I'm talking about if you get a good night's sleep and you feel good, you go, okay, I need to be doing this. Poof. So that's why I think it'll probably help.
Gotcha.
I never quite studied
Yeah.
that, but scientifically it should
It
work.
should work. Gotcha.
So Shmaybe is my answer.
Maybe. Awesome. All right. Well, want to thank you so much for coming on the Elevate podcast. I hope our listeners, I can guarantee you they got something out of this, and I appreciate them tuning in. And we couldn't be on all the different platforms without our listeners and watchers. So once again, everybody smash that like button, subscribe, hit the bell to get notifications when we put up new content. If you've heard anything today with Dr. Lipov, make sure you share this with the people that you may think may need to hear this message. That is so important. Please share, please share, please share. And I want to thank you again for coming on. And if you have any other last words, we'll go ahead and wrap it up.
I feel elevated. Thank you.
Yes. Usually, oh my gosh, that's so funny you say that. I've had so many guests actually use the word elevate during their description of something as we're talking about mental health and their personal progress. And as soon as they say it, they go, and I'm like, marketing. I'm like, I think I got the name right. So, all right.
Great to meet you, sir.
Yeah. Nice to meet you. Thank you so much. And I appreciate it.
Take care.
We'll be in touch, and yeah, take care, everybody.
Thank you. Take care. Bye-bye.
That's a wrap for this episode of Elevate, brought to you by Frontline Empowerment Solutions, your partner in building resilience and fostering continued growth. If you found something valuable today, don't keep it to yourself. Share it with someone who could use it. Don't forget to like, subscribe, and hit the notification bell so you never miss out on our next conversation. We're here to bring you more stories and insights, all aimed at strengthening the first responder community. Together, let's keep elevating each other, one episode at a time.